Hi everyone, we start the second part of the mesentery and omentum series with the topic mesenteric cyst. Mesenteric cysts are of various types: chylolymphatic, mesothelial, enteric duplication cyst, urogenital, dermoid cyst, or pancreatic pseudocysts. Most of the textbooks mention that the chylolymphatic cyst is the most common of all mesenteric cysts. However, Sabiston textbook of surgery mentions that the mesothelial cysts are the most common non-neoplastic mesenteric cysts. So, mesothelial cysts are the most common non-neoplastic mesenteric cysts. What do these cysts contain? These cysts contain serous fluid, or they may contain chyle. Okay, so chyle or serous fluid. Where are these cysts located? These cysts are located in the mesentery of the small intestine or colon. Cysts are most commonly located in the mesentery of the small intestine, that is 60% of the time, and the rest 40% they are located in the mesocolon or the mesentery of the colon. These mesothelial cysts are more common in adults, and out of the adults they are more common in women. Symptoms of a mesenteric cyst consist of abdominal pain, fever, vomiting, and a palpable mass. The picture on the left is a CT scan of a mesenteric cyst. We can see how big the cyst actually is, and the intestines are pushed to the sides. We can also take a look at the picture on the right, that is an ultrasound of a mesenteric cyst. This particular cyst appears uniloculated, and there are certain heterogeneity here in the cyst. The surgical treatment for a mesenteric cyst is enucleation of the cyst, and enucleation is curative. What we do in enucleation basically is that we peel off the cyst from the surrounding layer, which may appear to be adhered to the cyst. That is, the cyst is pulled to one side with traction, and the surrounding tissue which is attached or adhered to the cyst is pulled to the other side. In that way, the cyst is separated from the surrounding tissue, and this process is called as enucleation. If the cyst is very large, if enucleation is not possible, then an internal drainage can be done. That is, we can take a bowel loop over here of jejunum and make an anastomosis between the cyst and the bowel wall. Thus, the cyst fluid will drain into the intestine. That is called as internal drainage. Aspiration can be attempted, but it has got a very high rate of cyst recurrence. Okay, so aspiration has got a very high rate of cyst recurrence. Therefore, curative treatment and the treatment of choice is actually enucleation of the mesenteric cyst. After mesenteric cyst, we move on to the next topic, that is acute mesenteric lymphadenitis. The picture on the left is an ultrasound photo of acute mesenteric lymphadenitis. We can see that the mesentery is here like this, and these are enlarged lymph nodes. It's a painful condition, and these enlarged inflamed nodes causes the symptoms. There's the bowel loop on top over here. So basically, the patient presents with acute right lower quadrant pain. The problem is that with right lower quadrant pain, this condition can be confused with acute appendicitis. But in this particular case, the appendix is normal and the lymph nodes are enlarged. Alright, so that is acute mesenteric lymphadenitis. We have got a normal appendix, but the lymph nodes are enlarged and inflamed. What used to happen historically was these patients used to present with acute right lower quadrant pain, and because at that time there was no ultrasound, so mesenteric lymphadenitis could not be made out. So these people used to undergo laparotomy to make a diagnosis of acute mesenteric lymphadenitis when appendix was found to be normal intra-op. However, nowadays most of the cases are diagnosed with imaging. Epidemiologically, the syndrome most commonly occurs in children and young adults. Various pathogens are implicated, various bacteria, viruses, but there is one organism whose name is mentioned very clearly in our textbook, and that is Yersinia enterocolitica. It is implicated in acute mesenteric lymphadenitis in children. Moving to signs and symptoms, as I've already said that this condition mimics acute appendicitis, so symptoms and signs are very similar to acute appendicitis. That is, they start with a periumbilical pain which moves to the right lower quadrant. In the right lower quadrant, tenderness is seen, abdominal wall rigidity is present, and rebound tenderness is also seen. Therefore, rebound tenderness is also present in acute mesenteric lymphadenitis, a very important point. Patient can also present with nausea, vomiting, diarrhea, and may also present with anorexia. White blood cell count is raised in most of the patients. Therefore, mesenteric lymphadenitis is very similar to that of acute appendicitis. Clinically, it is very difficult to differentiate between the two, almost impossible. Therefore, abdominal ultrasound is recommended in all patients. Abdominal ultrasound will provide definitive diagnosis of mesenteric lymphadenitis and will prevent unnecessary surgical exploration. Moving on to the next topic of sclerosing mesenteritis. Before we begin the topic, we need to understand what is happening. It is a chronic inflammatory condition. Basically, lot of inflammation is happening in the mesentery, and the root of the mesentery, which we discussed in the first video, becomes the main victim of this inflammatory process. This is a histological section of that of a mesentery. We can see many different things happening in this histological section. Firstly, we can see that there are a lot of collagens here. These are all areas of collagen depositions in the mesentery, which are suggestive of a chronic inflammatory process. If we take a look at these arrows, it points towards these areas of inflammatory cells which have infiltrated into the collagenous area. These white areas are that of fat necrosis. So this is the histological picture of sclerosing mesenteritis. Alright. So sclerosing mesenteritis is an inflammatory disease of the mesentery which is characterized histologically by a variety of features like sclerosing fibrosis, fat necrosis, focal calcification, chronic inflammation with germinal centers. Okay, so germinal centers also can form. Before we talk about the description, let us look at the diagram on the left. We can see that this is the bowel. All right, this is the bowel, and this is the mesentery of the bowel, in which there are blood vessels and lymphatic supply and stuff. If we observe very closely, there are these whitish areas. All right, these whitish areas suggest that there is some kind of chronic inflammation going on, because of which there is fibrosis, and after fibrosis has occurred, there is a pull of the mesentery towards the root of the mesentery, and that leads to the kinking of the bowel, seen like this, seen over here. There is also kinkings, and these kinkings eventually produce something called as intestinal obstruction, and that is when surgery is required. So that is a basic summary. Now we will read. Early in the course of the disease, the mesentery is not like what we see in the picture on the left. It is loose, but it has a slightly thickened myxomatous appearance, which will eventually progress to a dense sclerosis. Okay, it becomes very thick. After some time, the mesentery becomes grossly thick. There are areas of discoloration, and there are multiple discrete nodules which form in the mesentery. Sometimes the sclerosing action of the inflammation is so extensive that the entire bowel and mesentery may form a single matted mass. They may form a single matted mass. So we need to understand that the entire mesentery is involved somehow, but the root of the mesentery is the main victim. I mean, most of the inflammation is happening at the root of the mesentery. We can also see calcifications like this, and the root of the mesentery is affected, and the bowel is, these are bowel loops. These bowel loops are pulled towards the root of the mesentery. That is going to cause the kinking action on the bowel. This is again the reiteration of the fact that the small bowel gets retracted with shortening of mesentery. It is not without, it is with the shortening of mesentery. The small bowel mesentery is more commonly affected compared to the large colon mesentery. Okay, so small bowel mesentery is more commonly affected compared to mesocolon. Sclerosing mesenteritis is more common in males and usually affects people in the 5th decade of life. As I've already discussed, that there is some kinking action on the intestine which leads to the symptoms of intestinal obstruction. Abdominal mass may be palpable in more than 50% of the patients. Because this mesentery becomes so thick and hard, it can somehow present with abdominal mass. Lab investigation parameters are usually normal. However, there is raised ESR and raised CRP. This condition doesn't only cause problems to the patients but also to the doctors or the surgeons, because they need to differentiate the condition from various other conditions. There are a lot of differentials like peritoneal carcinomatosis, carcinoid tumors, mesenteric and retroperitoneal sarcomas. That is why the initial investigation and the best investigation is CT scan. There are various features of the CT scan. One feature is a pseudo tumor. We can look at the diagram on the left. This is a mass which is arising from the mesentery. There are certain sclerosing areas, certain heterogeneous looking areas, and that is a pseudo tumor. This pseudo tumor seems to push the bowels away. Next, we move on to the tumor pseudocapsule sign. If we take a delayed photograph or a delayed scan, we can see a delayed enhancement around a mesenteric root sclerosed area, and this delayed enhancement presents to us as a pseudocapsule. Therefore, this is the pseudocapsule sign. The next sign is called as the fat ring sign. We need to notice carefully that these are the areas of blood vessels, and surrounding that there is this dark area, if we can notice carefully, and surrounding the dark area there are again these sclerosed area. These dark areas are preserved fats that gives it a ring like appearance. So there is blood vessel, there is preserved fat, and there is surrounding sclerosed area. That is called as the ring sign. There is another ring sign we can observe over here. There is blood vessel, maintained fat, and there is sclerosed area. So these are called as ring signs. For the definitive diagnosis, laparotomy or laparoscopy is required with biopsy. Biopsy is required because we have discussed that we need to differentiate this condition with other conditions like retroperitoneal fibrosis and retroperitoneal sarcomas. Most of these patients usually experience spontaneous resolution without doing anything. So sometimes we just need to wait and watch. However, for severe cases, corticosteroids or other immunomodulators are given. Surgery is only indicated in case of intestinal obstruction. With that, we come to the end of the lecture. I really hope you like it. Kindly subscribe. But most importantly, follow the Telegram channel whose link I will be sharing in the description for daily questions, daily MCQ practice on topics from Sabiston and Pelian Love's Textbook of Surgery. So thank you so much.